Good surgery requires that everything should be perfect, and at times there may be surprises during the surgery, and here we will see that after the IOL is implanted there is a surprise. This is the individual who was planned for cataract surgery, and it's a dense white mature cataract which is rather unusual in present day. And this is the B scan which was done just to evaluate the posterior segment, which is unremarkable, and this is the case which has been started. The capsule has been stained with trypan blue dye so as to visualize the capsule clearly and perform a rhexis. Once the rhexis has been done, a side port is fashioned and hydrodissection is done, although in white cataracts this is one optional step, but if you find the cortex is not really liquefied, you can do a hydrodissection. So the surgery is started, and the method to be used is primary horizontal chop, in which multiple chops are done from periphery to the center of the tip where the tip is holding the nucleus, and then the pieces which are chopped are emulsified. This part of the video is accelerated just to reach early to the point of interest, and however at the same time not omitting any of the steps. So it's a rather unremarkable surgery, except it is a white cataract, and these cataracts don't have much cortex left behind. So this is the IOL which has been implanted, and it looks pretty fine up till now. And there's one comment which I would like to add here is that this is one of the preloaded IOLs, and my assistant just forgot to put viscoelastic gel on one of the ends, which is mandatory before injecting the IOL. And then I realized, and I then opened up the cartridge and put some visco there, and then I folded and proceeded for implantation. However, to my surprise, in spite of everything going fine, the IOL was just not centering. So the haptic was visible to me and it appeared fine. But when I redialed it, at this moment I realized that one of the haptic is actually truncated, and that is the reason why the IOL was not getting centered. Now at this moment it is a pain because one has already implanted the IOL and the IOL has unfolded. So one has to remove this IOL, and for that either the IOL has to be cut or folded, or the wound has to be enlarged. So there's one trick which is known as twist and pull, which I have learned from videos which I have seen online, especially from Dr. Uday Devgan video, where this can be done by folding the IOL inside the anterior chamber. So you pull out the IOL from the bag, place it in the anterior chamber so that the haptic is directed towards the wound. There may be requirement to just funnel the incision so that the broader side is inside, so that the IOL can be accommodated and can aid in folding itself. The dialer is used to align the IOL so as to align it for the lens holding forceps. So this is a Kelman lens holding forceps, and once the IOL with the haptic and the optic junction is held, the dialer is supporting the grip, and then you place the IOL over and above the optic part, and you simply twist the IOL so that it gets folded, and the dialer overlying it supports this folding movement. And this twist will simply roll the IOL and it can be easily pulled out. Once it has been pulled out, a new, fresh, undamaged IOL is implanted in the eye and the surgery is done. Although the incision was slightly enlarged, but doesn't matter much because the incision was already in the steep axis. This is the post-op day 1 photograph where we can see some eccentricity in the pupil, and which I don't know why it occurred, but later on at week 1 this is the picture which shows a perfectly sized pupil and a perfectly centered IOL with patient having vision 6/9 and improving to 6/6. Thank you.